Okay. So, but I can also do a recap. I said the production of cortisol peaks around 6 to 8 a.m. in the morning, and that's because, like we said, it makes glucose available to the brain. It tells your brain it's morning time, then you need to get up and work and all of that. So I believe we must have discussed that. Then we said that this rhythm is influenced by sleep and light exposure, which affects the hypothalamus. Okay? All right. Now, then I said, particularly for those who run night shifts, it's a problem because your hypothalamus kind of like resets. Okay, and why is the hypothalamus very important? The hypothalamus is important because it produces corticotropin releasing hormone, which stimulates the adrenal gland to produce the adrenal corticotropic hormone, and that in turn stimulates the adrenal cortex. What region of the adrenal cortex produces the cortisol or the glucocorticoid? Okay, I guess you guys have not started.
Not vasculature.
Okay, the fasciculata produces the glucocorticoids. Okay, basal production. Now let's go into the physiologic effect of the glucocorticoids. Now, like I said, the name glucocorticoid means that they are going to make glucose available, all right, or that they are involved with the metabolism of glucose or carbohydrates in general. That's why we refer to them as glucocorticoids. On the other hand, the mineralocorticoids will, of course, be involved in the, we won't say metabolism of minerals, but of course they will make maybe increase or reduce some minerals as the case may be. All right. So and that's why we call them mineralocorticoid, because their own engagement is with the minerals like sodium, potassium, as the case may be. Okay. So for the glucocorticoids, it's basically carbohydrate metabolism. Then let me tell you the thing about the metabolic effect of glucocorticoid is that it has a paradoxical effect. If that's what I should use, it can cause lipolysis, okay, which is the breakdown of fat. Then it can also cause lipogenesis, okay, which is the buildup of fat. Okay, so the metabolic effect is somewhat paradoxical. Okay, the same thing, it can cause gluconeogenesis, meaning that it makes glucose available, and it can also cause glycogenesis, or it can convert glucose into glycogen. Is there a question? Does anyone have a question? Okay, all right. So let's go straight into the physiologic effect of the glucocorticoids. Now, yeah, it stimulates. The most important thing is that it wants to make glucose available to your brain. So the most important organ for the glucocorticoid will now be the brain. Okay, the glucocorticoid want to make glucose available to your brain so that this day can kickstart. Okay, now how does it do this? It stimulates gluconeogenesis. I've explained gluconeogenesis in the last class. That neo means from other non-carbohydrate sources like protein and other non-carbohydrate sources. So what the glucocorticoid will cause is the breakdown of nutrient like protein to make amino acids. Then it will now convert, it will now help with the conversion of the amino acid into glucose. Okay, so now please, you have to be exact, precise, and specific when you are answering questions. Okay, we said it stimulates gluconeogenesis. Okay, it means that it makes glucose available from uh, non-carbohydrate sources. Now then, it reduces peripheral glucose utilization. There is something that the glucocorticoids have with the peripheral. Okay, so it reduces peripheral glucose utilization. Why does it reduce peripheral glucose utilization? It does this so that glucose, almost all the glucose can go to the brain. Like I said, the principal organ for the effect of the glucocorticoids is the brain. So the glucocorticoid will ensure that there is a reduction in the peripheral consumption of glucose, so that the glucose can be available, okay, for brain use. Now, they also inhibit glucose uptake. Of course, the peripheral, the muscle and the adipose tissue are part of the peripheral system. So okay, so it inhibits glucose uptake by muscle and the adipose tissue. Then another effect is that it promotes glucose storage, all right, in the form of glycogen. So this is what happens. The cortisol stimulates gluconeogenesis. Then glucose is made available. Then we can say excess glucose is made available. Then this cortisol also now promotes the storage. Glucose is stored. Excess glucose is stored in the body as glycogen. So the cortisol also promotes the storage of glucose in the form of glycogen. Now, The catabolic effect of glucocorticoid is almost the direct opposite of that of insulin, okay, because you know that insulin makes the peripheral tissue take up glucose. Okay, I'll repeat that again. Insulin makes the peripheral tissues use glucose. Okay, it makes them utilize glucose and not so that the glucose can be mopped up from the plasma, and in turn we have a reduction of the blood glucose. All right, but the effect of cortisol is the direct opposite. Cortisol inhibits the peripheral utilization of glucose to make the glucose available for the brain. So in a way, that's why we said chronic use of glucocorticoid can now lead to diabetic-like symptoms. Okay, because more or less what we can say there is that cortisol is causing insulin resistance. Who can explain insulin resistance to us? You guys are in 400 level. You have done a lot of clinical pharmacy and all and pharmacology, so you should be able to. Who can explain what insulin resistance is? Yes, go ahead. Go ahead.
So majorly it occurs in type 2 diabetes and is when the body is not receptive to the insulin present in the liver, allowing for the accumulation of glucose, and that will cause hyperglycemia in on itself.
Excellent, excellent. So that's it. The tissue becomes less sensitive. The peripheral tissue becomes less sensitive to insulin, and as a result of that, the glucose transporter does not. I've forgotten the physiological term. Does not relocate. That might not be the term, but I'll remember. Now, the glucose transporter does not relocate to the plasma membrane, where it now exchanges. It allows glucose to enter into the cells, and the tissues can make use of them. So, cortisol, what it does is close to insulin resistance, because it reduces the peripheral utilization of glucose so that the glucose can be available centrally. Okay, so that's why chronic use of glucocorticoids can cause diabetic-like symptoms, particularly insulin resistance. All right, so please take note of all these things. I don't want to bore you with the mechanism of some of these things, but let's explain the mechanisms of the inhibition of glucose uptake by the muscle and adipose tissue. Okay, it actually, the corticoids or the glucocorticoids actually do this by impairing glucose transporter translocation. Okay, now you see, glucose itself cannot on its own diffuse across the plasma membrane of the cells, so it requires a transporter. Now, and that transporter, we have to carry glucose across into the plasma membrane via facilitated diffusion. Now, so we call this transporter the glucose transporter, or GLUT for short. Okay, so you see, when insulin sensitizes the cells of the body or the tissues of the body, what happens is that the glucose transporter translocates. Yeah, that's the word I've been looking for, not relocate, sorry. Translocate from the cytoplasm, and they move near the plasma membrane to open the portal for glucose to diffuse into the cell by facilitated diffusion. Okay, so cortisol, glucocorticoids inhibit this glucose transporter system, and as a result of that, the peripheral tissues are not able to utilize glucose, and this is also a similar mechanism that we have in insulin resistance, and that's why chronic use of glucocorticoids can cause diabetic-like symptom, all right, or diabetes itself. Now, that being said, and you know, when we say glucocorticoids, of course, I already told you that corticosteroids are now synthetic forms of glucocorticoids. So whatever physiologic effect applies to cortisol applies to your corticosteroids like prednisolone, hydrocortisone, dexamethasone, and all these corticosteroids. So whatever effect we say for glucocorticoid also applies to them. Let's move. So please, you should take note of that mechanism. Okay, the effect on protein metabolism, it's also catabolic. It breaks down protein, like we said, and so that there can be gluconeogenesis. All right, so cortisol we break down, glucocorticoids we break down protein, so that there can be amino acids available for glucose synthesis, which we refer to as gluconeogenesis. All right, that's the definition of gluconeogenesis in a sense. So that's why the chronic use of glucocorticoids will also cause muscle wasting, all right, because we know that principally our muscles are made up of protein. Then it causes the thinning of the skin. It causes the thinning of the skin. We now become thin. It causes the thinning of the skin because a patient that is on dexamethasone for the sole purpose of gaining weight, all right, we eventually now start having thin skin now, and also the muscle will become wasted because these drugs rather break down protein and then cause a build-up of aggregation of amino acids into protein itself. So now let's now talk about fat metabolism, and this is an area where you have to properly educate your patient, particularly those ones that are crazy about butt lifting, increasing their butt size to impress a man who will eventually go for a small yash lady. You understand? So because the sincere truth is that the person you are trying to impress may not even be interested in the big yash and all of that. So now you need to know the complexity behind fat metabolism of corticosteroids, and that way now you can now appropriately advise your patients to stay off corticosteroids. The picture of a woman depicted here, what can you guys notice? Anybody, what are the things you think you can notice in this woman? So this is a typical person who has been under the influence of corticosteroids for a very long time. Okay, so let's say this person has been using corticosteroids chronically. So what are some of the things you can see? Anybody? What are some of the things you can see in this image? What are the things you can see in this image? Okay, if you can't see anything, then I'll be the seer on your behalf. All right, Mary Emanuela. You have
Good evening, sir.
Yes, good evening.
She has bloated stomach and sagging skin around the stomach area.
Okay, great. Now, I will now. Any other person? You are right. Any other person? What are the things you can notice from the image? Yeah. Okay, let me demystify the image. First, if you go to the scruff of the neck, you will notice that the scruff of the neck is kind of protruded. All right, so that's buffalo hump. And in fact, when it comes to fat metabolism by the corticosteroids, we refer to it as Cushingoid fat distribution. Cushingoid fat distribution. Okay, Cushingoid fat distribution. I might be asking you to briefly explain Cushingoid fat distribution as an effect or side effect of corticosteroids or glucocorticoids. Okay, so when it comes to because it's of public health importance, particularly for ladies who have been wrongly told that corticosteroids can increase their butt size. So now the first thing we notice is that if you check the scruff of the neck, is kind of fatty and protruded. So this is what we call buffalo hump. All right. If you know, the face too is puffy. That's what we refer to as moon face. Then if you check the gluteal region, the butt is going in. All right. I don't know what we are going to call that one, but the butt is going in. Then the abdomen, there's also central obesity. That's what you can see here. Central obesity. Okay. Then if you check the skin, you will see what we refer to as striae. I don't know if I'm pronouncing it well. STRIAE. It's a medical term for stretch marks. Okay. And one of the woes of chronically consuming corticosteroids is that eventually you start having stretch marks. Okay. You know, we talked about skin thinning. All right. Then there will also be stretching of the skins of the central region. Okay, so you might eventually now start having stretch marks on chronic and prolonged use. Then another thing to observe is that the legs are thin. Okay, the legs are very thin. Now, and this is also as a result of fat redistribution, the Cushingoid fat redistribution that we are talking about. So if you see someone who has used corticosteroid for a very long period of time, you see that the legs will now start looking like toothpick. Okay, like some people used to say. We are not trying to body shame. Of course, this is a cartoon image, so we cannot say we are body shaming this image. All right, but the thing is that the Cushingoid fat distribution, all right, moves fat from the limbs, both the upper limbs and the lower limbs, the legs and the limbs, and from the gluteal region, it redistributes the fats to the abdomen, to the scruff of the neck, and the face. Okay, so in debate, we now say, I hope with this few point of mine, I've been able to convince you and not confuse you that corticosteroids cannot lift the butt. So it's a lie from the pit of hell. In fact, it does the reverse. Now, just like the paradoxical metabolic effects of glucocorticoids, they also have this paradoxical metabolic effect when it comes to fat metabolism. Okay, they can cause lipolysis, they can also cause lipogenesis. Now, so they cause lipolysis of the region like the gluteal region, the upper limbs and the lower limbs. Then they now cause lipogenesis of the abdomen, the scruff of the neck, and the face. Okay, so this description is what we refer to as the Cushingoid fat distribution. Please, any question? Is it clear to you? So in case I now ask you in the exam, briefly explain the Cushingoid fat distribution. Yes, go ahead, Emmanuel. You have the floor. You can
Sir, please.
Yes.
Can I just go over the explanation on the lipolysis and the lipogenesis on the distribution?
Okay. Now, anytime we say lysis or lipolysis, anytime you hear lysis, it means breakdown. Then we say genesis, it means build up, kind of. Okay. Glucocorticoids or corticosteroids can cause lipolysis. Okay. They can also cause the opposite, which is lipogenesis. So these are part of the paradoxical metabolic effects that I'm talking about. The same thing happens for glucose too. They can make glucose available. They can also convert glucose to glycogen. All right. Now, so this is another way to ask to kind of give you questions and say, also describe the paradoxical metabolic effect of corticosteroids. So lipolysis, let me not talk too much. Let me answer your question. Now, it causes lipolysis of some regions of the body. It means that it breaks down the fat. Then it causes lipogenesis in other regions. So it means that those regions will now have very high fat deposit. Okay. So the explanation I made is that your limbs, upper limbs, lower limbs, the gluteal region. Now, the lipolysis will happen in the upper limb, lower limb, and the gluteal region. In fact, it's more like an embodiment of disfigurement. The person will eventually be disfigured eventually. So there's lipolysis, fat breakdown in the limbs and the gluteal region. Then there will now be lipogenesis of the scruff of the neck, the abdomen, and the face. Okay, so fat broken down will now build up in the stomach, on the neck, and on the face. Okay, so the person would have a face like puff puff, the Nigerian puff puff. Okay, so in pharmacology we call that moon face. Then there will be more like a fatty neck that's called buffalo hump. Then there will now be what's it called, pot belly. Now, all these things we are saying will not only happen in people who are misusing corticosteroids. It will also happen if you are subjecting yourself to chronic stress. Like I said, as you become a man and you are responsible and you work during the day, work all night, you are working yourself out to make a lot of money to put food on the table and make the family running and all of that. If you are not getting adequate rest, it is not just only alcohol that can make your belly shoot out. Even the chronic cortisol in your body, as a result of the stress, constant, incessant stress that you are subjecting your body to, can make your belly shoot out. Okay, so I hope I've been able to explain these lipolysis and lipogenesis. Do you guys copy that? Or I have to still go over it again? It's still more like a paradoxical thing when it comes to metabolism. Okay, so if you got that, let's go on to the CNS. Now, when there is glucocorticoid insufficiency, there can be depression, lethargy, and irritability. And why do we have that? Okay, now we said that the principal organ that is the target of the glucocorticoid is the brain. So when there's glucocorticoid insufficiency, then you can start having symptoms like depression. Then because glucose will not be available to the brain, then we can have lethargy. And then the patient may be irritable, right? Because everything will just be almost wrong with the brain, because the brain is not getting the glucose it's supposed to get as the principal organ of the glucocorticoid. Now, in contrast, if we have glucocorticoid in excess, particularly acute excess, it can produce excitation and euphoria. Okay, so it means that you can also get high on glucocorticoids and produce excitation and euphoria, you can get high on glucocorticoids, kind of, in a way, technically, in a sense. Okay. Um, Now, you know that generally the adrenal gland is for the maintenance of, particularly the medulla, makes your epinephrine and norepinephrine, which have pressor effects and maintains the blood pressure. Okay, so but the epinephrine and norepinephrine do not maintain the blood pressure alone. They also do that with the help of the adrenal cortex, with the help of the glucocorticoids. All right. So, and what happens generally when you are subjected to stress, you need cortisol. Okay, the adrenal cortex needs to make cortisol, and the adrenal medulla also needs to make epinephrine. Both of these will serve to maintain blood pressure and also make glucose available. Now, so the essence of this is that when we have glucocorticoid insufficiency, it can cause hypertension, it can cause hypoglycemia. All right. Now, then for a patient that has adrenal insufficiency, you need to give the patient glucocorticoid before the surgery, because if you do not, surgery is a condition of extreme stress. The patient may experience circulatory collapse and die in the process. Now let's talk about another physiologic effect of glucocorticoids. Now, when a woman is at term, okay, that means the fetus had grown to full term, and which should be about 38 weeks or thereabout. Now, the adrenal gland of a full term, of a mature fetus, has to, during labor and delivery, it has to make excess glucocorticoids, okay, within hours. Why does it have to make excess glucocorticoids? It has to do this for the maturation of the lungs. Okay, you know that the fetus in the mother's womb, the lungs is not fully mature, and the lungs is not fully mature because the child, okay, depends on the gaseous exchange of the mother too. You know that there is a connection between the circulatory system of the child and the mother in the fetus. In utero. Okay, there's a connection. In utero is the term, in the uterus. There's a connection between the circulatory system of the mother and the child. So what makes this connection? Anybody who can tell us what makes this connection? You did embryology. There's a connection between the circulatory system of the mother and the child. Your embryology, and so many of you passed embryology now. But also tell me. Nobody knows. Yeah, Bemisola.
Good evening, sir. Through the umbilical cord, sir.
Yes. Through the umbilical cord, then more or less there's an uteroplacenta circulation. Okay, so now, so in essence, it means that the child can get oxygen through this circulation. It necessarily does not have to get it via the lungs. Okay, and it can also get rid of carbon dioxide. Yes, Bemisola. Yes, Bemisola. Or everybody raising hand. You have the floor. You can unmute. Oh, okay. Maybe she raised the hand by in error. Now, so you see that a child does not necessarily have to depend on the lungs to get for gaseous exchange, because the circulatory system of the mother and the fetus, in the womb. When I say the child, please know that it's fetus in the womb. All right. The child does not necessarily. Let me not say child so that you won't confuse this thing. The fetus does not really use the lungs in utero. Because there's a compensatory circulatory system from the mother, and this compensatory circulatory system does the work of gaseous exchange during labor and delivery. Then the adrenal gland, particularly the zona vasculata, should release excess glucocorticoids. Now, these excess glucocorticoids, we now within hours mature the lung. It will mature the lung. Okay, so in this maturation, we now make the child independent of gaseous exchange via the uterus placenta circulation. Now, so but for a preterm infant, a fetus that is not up to the required number of weeks, this child will develop respiratory syndrome, distress syndrome. all right, because the lungs will not be mature enough. Now, so how do we do this? We resolve it by giving betamethasone. You give betamethasone to the mother, and via the same circulation, this can mature the lungs of the child. Any question? We thank God. Yes, yes.
So please, you said something about betamethasone.
Yeah, betamethasone. Yeah, that's what you give.
Right? Is it that we've given what to the baby already? Is it that I don't understand? You administer that we administer it through the mother or something like that. I don't really understand.
I said before labor, you give to the mother.
Okay.
Yes. Yeah.
Are you baby?
Yes, go ahead, please. Okay, let's go to the next slide. It's actually interesting. Corticosteroid is more than inflammation. Okay, although the basic thing, we have the steroidal inflammatory drugs and we have the non-steroidal inflammatory drugs. Okay, so the non-steroidal anti-inflammatory drugs are the corticosteroids. Sorry, the steroidal anti-inflammatory drugs are the corticosteroids, while the non-steroidal anti-inflammatory drugs are your NSAIDs, your diclofenac, and all of that. Okay, so now the steroid anti-inflammatory drugs are majorly for what's it called, for inflammation. Then the non-steroidal anti-inflammatory drugs too are for inflammation, pain, and all of that. Okay, so aside them being anti-inflammatory agents, they also have other physiologic effects, which are some of the things we have discussed. Okay, now I was going to say something. I can't remember. That's why I've been stuttering now. I was going to say that you see, medical when it comes to medical outcomes and all of that, it might not be as a result of one thing alone. Okay, so I talked about respiratory distress syndrome. Okay, so that, of course, we have so many differential diagnoses when there are a lot of issues. So your baby not crying, that may just be one of the reasons, all right, but also we may have some other things. A lot of things can also cause it. Okay, they just see that crying as, this is a normal response when the mother is delivered of the baby. Okay, that you don't say that she just deliver. No, when we use the word deliver when it comes to childbirth, it's more like deliverance for the mother. So you say the mother has been delivered of the baby. Okay, not that the mother has delivered a baby. No, you have delivered the mother of a baby. So we say the mother has been delivered of a baby. Now, other physiological effect is the suppression of lymphocyte function. Glucocorticoid reduces immunity. All right, they reduce immunity. They suppress lymphocyte and function, and in fact, that's why they have an indication as immunosuppressant when we are thinking about organ transplant and some other things that may trigger the immune reaction. Then we can think of glucocorticoids for immunosuppression. Now, as a result of that too, like I said, when you have high cortisol in your body, particularly under a stressful condition, then you can be susceptible to illnesses too. All right, these illnesses just take opportunity of your immunosuppression, and I related that to the exam period, either pre or post, when the tensions are high and you're already exerting yourself so that you can also scale through. Eventually, the high cortisol level may crash your immunity. Depending on the extent, this can lead to, you may now start having things like malaria and all of that. This increases the parasite number in your blood, and you may fall sick and all. So they also inhibit pro-inflammatory markers, pro-inflammatory cytokines like interleukin-1, 6, TNF alpha. We'll see the mechanism for these. Okay, they also inhibit the enzyme COX-1 and COX-2. Now, these effects are crucial for managing inflammation. We don't need this. We already said it. Now, how do glucocorticoids act? When it comes to mechanism of drug action, some drugs act on cell surface receptor, while some drugs can enter into the plasma membrane and go into the cytoplasm and interact with receptors in the cytoplasm, and also interact with the nuclear receptors and cause the upregulation of specific genes. Now, if a drug or if a compound, if a biomolecule is highly lipophilic, there's a large extent that biomolecule will not interact with cell surface receptors. Okay, hormones hormones that are peptides, okay, because they are hydrophilic in nature, they interact with cell surface receptor. They cannot cross the plasma membrane, so they interact with cell surface receptor. Some of them interact with G protein coupled receptor, interact with ligand gated ion channel, and quite a number of things. So it is this receptor that now changes conformation, and when it changes conformation, in the case of G protein coupled receptor, it activates G alpha. Then there's a cascade of events. Then there's an effect. Now these are for peptide hormones that are hydrophilic, that are have high molecular weight and all of that. They cannot enter into the cell. But for corticoids, glucocorticoid, mineralocorticoid, and the likes, they are highly lipophilic, and because they are highly lipophilic, they can enter the plasma membrane and interact with cytoplasmic receptors. And when they interact with cytoplasmic receptors, they can also now interact with nuclear receptors, or move into the nucleus rather, all right, and cause the upregulation or the expression of certain genes. Now, so this is what happened. Glucocorticoid cross the plasma membrane, interact with cytoplasm receptor. Now, this receptor glucocorticoid complex then go to the nucleus and cause the expression of certain genes. So this is how they act. Now, and because of this long path or route, sometimes you don't get an immediate effect when you take corticosteroid. You may have to wait for some few days before you start seeing full effect. And the reason is because this part, it takes time for this part to happen. Now, unlike your cell surface receptor, is very rapid. The effect takes place, particularly for ion channel, the effect takes place very rapidly. But in the case of corticosteroids and glucocorticoids, it takes time because they cross the plasma membrane, they interact with cytoplasmic receptor, and this receptor complex now moves into the nucleus. And you know the nucleus itself has its own nuclear membrane and all of that. So all this movement takes time. So it might take time for you to see some of the effects of corticosteroids. So when somebody comes and you give corticosteroid and the person is saying, I'm not even seeing the work, you already know, because you have been equipped with the knowledge that it takes time, because they may have to go into the nucleus and influence expression of genes. Okay. Now, but also they can also interact with cell surface receptor. So that's why some corticosteroids can be used in cases of emergency, okay, because they can interact with cell surface receptor. Then as you now keep using, you now begin to see other effects, which will now come via the influencing of gene expression. Okay, so glucocorticoids can have two different mechanisms of action. They can interact outside the cell, then they can interact inside the cell. Okay, and these two mechanisms of action are very important. Now, take for instance, we use hydrocortisone a lot in emergency, and the reason is because hydrocortisone is by far like the fastest acting, it's very rapid, the fastest acting corticosteroid. So it's an emergency drug. In fact, it should not be out of stock in any standard hospital, because hydrocortisone is a standard drug. It's just a patient can be rushed in, the patient is hypoxic, it might be due to asthmatic attack, it might be due to chronic obstructive pulmonary disease. Okay, there's sharp bronchospasm, bronchoconstriction. You can jab hydrocortisone. It's not only inhaler, you can also jab hydrocortisone, and the patient will jolt back to consciousness. Okay, then a patient that has gone into anaphylactic shock, and you want to resuscitate the patient. In fact, generally for resuscitation, hydrocortisone is an important drug. Now, then in case of allergic reactions in the hospital, when you are transfusing blood, regardless of your cross matching, your patient will still react. I don't know if you have ever been taught that. Okay, so when you are transfusing blood, you have already done cross matching. Okay, but even at that, beside the patient's bed, you have to keep antihistamine, hydrocortisone, furosemide, which is a diuretic. You have to put these three drugs beside your patient, and probably paracetamol. Now, the reason why you have to put these categories of drugs, paracetamol, because the patient may develop pyrexia. Now, there might be some things in the blood that you didn't screen, like malaria parasites and the likes, and as you are transfusing the blood, your patient may start developing pyrexia. Okay, so you give paracetamol. Now, then, because the blood has a lot of proteins, and we cannot always do the compatibility of all these proteins, so we do the most important ones. Okay, there's also a very high tendency that your patient will react to that blood transfusion, so you keep antihistamine injection close to the patient, then you keep hydrocortisone close to the patient. Once you notice any allergic reaction, or any, sorry, not allergic, and once you notice any reaction to the blood transfusion, you immediately give your patient these medications. Then why furosemide? Now there may be a volume overload, and once you observe volume overload, you just give furosemide and the volume overload goes down. Okay, so now this is where we are going to stop. I will show you one more slide. I usually don't want to be doing more than an hour. We just keep it at that, an hour, then I think we are going to finish. Now I believe you can see. Oh, let me expand this very well. If I expand this, you won't be able to see. Okay, but let me. I'm not projecting this slide. Okay, so let's see the anti-inflammatory action of corticosteroids. Okay, generally, our cell membrane is a phospholipid bilayer. You must have heard that from your basic physiology. It's a phospholipid bilayer. Now, and most of the time, this phospholipid get converted into arachidonic acid by the enzyme phospholipase A2. Okay, now this arachidonic acid can be converted into leukotrienes by the enzyme lipoxygenase. Okay, now arachidonic acid then via cyclooxygenase or the cyclooxygenases can be converted into prostaglandins, thromboxane, and prostacyclin. Now prostaglandin is important for vasodilation, thromboxane is important for platelet aggregation and vasoconstriction. Okay, then prostacyclin is important for platelet disaggregation and vasodilation. Now excuse me, your cyclooxygenase is inhibited by your non-steroidal anti-inflammatory drugs, while phospholipase A2 is inhibited by your steroidal anti-inflammatory drugs. Okay, so but let me explain something to you. You cannot use NSAIDs for all types of inflammation. You know, the asthmatic condition is a chronic inflammation. So who knows why, since NSAID is an anti-inflammatory, who knows why NSAIDs are not used for asthma? Why? Since they are anti-inflammatory. Yes, Mawuya.
NSAIDs inhibits COX, and they more of, I would say, they don't inhibit the LOX formation, causing vasoconstriction, and that can further aggravate asthma patients. Why the COX? I believe most of what it does was vasodilation, and that is what is needed in asthma patients.
Okay, yeah, thank you. Yeah, you are right. If I would grade you, I would give you like 80%. But let's follow the premise you have given us. Now, why are NSAIDs, since they're anti-inflammatory drugs, why are they not used for asthma? Okay, so now this is it. For the inflammatory condition in asthma, like Mawuya said, the leukotrienes are implicated. Okay, the leukotrienes are implicated. You can see leukotrienes here. Now, and the pathway to leukotrienes is before the pathway NSAIDs work on. Okay, the pathway for leukotrienes is before the pathway NSAIDs work on. So NSAIDs do not work via that mechanism. Now you see that the very first thing in this pathway is what corticosteroids work on. It inhibits phospholipase A2, which converts phospholipid to arachidonic acid. Okay, now this is what corticosteroids inhibit, and that's why corticosteroids can be used for asthma. It can also be used for arthritis that you use NSAIDs for, because corticosteroid is what in the content creation parlance that we call the oga patapata of them all. So corticosteroid works at the very beginning, so you can use it for both asthma and you can use it for both asthma and other skeletal inflammatory conditions like arthritis and osteoarthritis. Now, but you cannot use NSAIDs, one, because the mechanism is after the formation of leukotrienes. It does not have anything to do with leukotrienes. If you inhibit phospholipase A2, you cannot get arachidonic acid. You can also not get leukotrienes. And the major inflammatory marker implicated in asthma are the leukotrienes, like I said. Now, the second reason why NSAIDs are not used is that if you use NSAIDs, it blocks the conversion of arachidonic acid into prostaglandin, thromboxane, and prostacyclin. And as a result of that, once you block this, the conversion of arachidonic acid to leukotrienes will be upregulated. So technically, NSAIDs are contraindicated in asthma, because once you block the cyclooxygenase pathway, you upregulate, you increase the lipoxygenase pathway, and once you increase the lipoxygenase pathway, leukotrienes are made available in whatever, and they can now cause bronchospasm and bronchoconstriction. Now, this is more like a theoretical thing. Some people say it regularly does not occur in clinical practice, but you still have to warn your asthmatic patient from regular use of NSAIDs, because it can make them more susceptible to frequent attacks than they can know. Okay, now if your asthmatic patient is regularly having frequent attacks, you may want to see if the person is also chronically using NSAIDs, because if the patient is chronically using NSAIDs, it upregulates the leukotriene pathway, and once there is excess leukotriene, you can then now start to have regular attacks, regular asthmatic attacks. Do you understand this explanation, or do I have to go over it again? So if I ask you a question like, why do you think NSAIDs might be contraindicated in asthmatic patient, you should be able to tell me from this pathway that this is the reason. Once you block COX, LOX is upregulated. LOX is lipoxygenase. So once you block COX, you are upregulating LOX, okay, or lipoxygenase. And once you upregulate lipoxygenase, there might be excess leukotrienes. So like I said, some asthmatic patients will say, oh, they use NSAIDs occasionally and it does not trigger them. Why some will say NSAIDs, God forbid, it triggers them. So that's why some people say is of average clinical relevance, but still you have to still appropriately advise your patient. So that's why, yes, Jesunifemi, you have the floor.
Okay, so I have a question.
Okay,
So I want to ask, NSAIDs like aspirin that is used for vasodilation and also has antiplatelet activity. Like, what's the mechanism of action there? I think that it does not block the COX enzyme.
I'm trying to get your question. The aspirin is used for.
Yes, like it's NSAID, but like it's like it has little antiplatelet activity.
Yeah, sorry. Okay, vasopressin. Sorry, someone came to check me. Now, aspirin is an antiplatelet. Okay, that one is straightforward. Now, if you see from the diagram of this mechanism, once you inhibit COX, then there will not be, you will not have thromboxane. Okay, and once you don't have thromboxane, there will not be platelet aggregation. All right, so that is that. So from that, it's clear that that's our mechanism. Then, who says aspirin causes vasodilation? It's more for platelet aggregation. Have you been taught that aspirin causes vasodilation? Aspirin, what it does is that it inhibits platelet aggregation, and it does so irreversibly. Yeah, go ahead. Just yeah, go ahead. Your hand is raised. I don't know if you have raised it previously or you just raised it now.
No, I've read it previously, sir.
Oh, okay. So aspirin is used for as an antiplatelet. Then also, well, primarily what is used for is as an antiplatelet. Any other questions? Sorry, any other question? Okay, so if there are no questions, I think we have almost wrapped up. We're almost wrapping up this pharmacology of the adrenal, whatever. The next thing we just move to will be the pharmacological uses of and the adverse effect of corticosteroids. So that's what we'll be moving into. Then we now talk about adrenal insufficiency and glucocorticoid excess, that is known as Cushing's syndrome, and all that. Then that brings us to the end. Then I think I've wrapped up. I will now wrap up with you on that. What is the cause code of this one? Is it 403 or 41?
401.
401. Don't mind me. I'm not a very good lecturer. I should not be asking you for cause code. So in 403, I'm still going to take you anti-cancer, and it's a very wide topic. So But I think one more class we are going to wrap up this. Then we now do anti-cancer, and that brings us to the end of our my pharmacology interactions with you guys this semester. So any question? Any question? You need to ask me questions. So if there are gray areas that you need me to clarify, because I don't know. I think the last time they gave me almost two questions in this thing. So if you have a question, ask me. But it might not be so this semester. It might just be one. So, but if you have gray areas, just ask me. But I think, but if you listen to the lecture note very well, you would already have more than 40 to 30% of my questions, because I already said some. If I ask you, if I ask you, if I ask you, so okay, all right. Enjoy the rest of your weekend. We are going to meet next weekend, hopefully, if you guys have a chance. 1 hour as usual, maybe 1 hour, 30, 15 minutes or more. Okay, so thank you.
Thank you, sir.